Alors, bonjour tout le monde, Francis Letourneau d'Institut Axis. Ça me fait plaisir aujourd'hui. Je sais qu'il va y avoir beaucoup de monde qui vont l'écouter en replay, mais merci aux gens qui sont déjà là. Là, on a déjà Claudie qui est avec nous. Salut Claudie. Et on a la chance de recevoir aujourd'hui DrAyla Wolf, qui est acupunctrice aux États-Unis. Elle était déjà venue au Québec, au Grand Times Hotel à Laval en 2024. Elle avait fait une super formation. En fait, elle en avait fait deux et qui avait été très appréciée. J'ai même un de nos collègues, Stéphane Surbide, qui m'a écrit, qui dit, Francis, les techniques, les tests qu'elle a montré dans le cours en 2024, j'utilise ça à tous les jours en clinique. Donc, c'est vraiment super pertinent. J'ai demandé aussi à Dr. Wolf si on pouvait avoir des exemples, admettons des tests les plus fréquents qu'on ferait en clinique et c'est quoi la pertinence? Parce que beaucoup d'entre vous m'ont demandé est-ce que c'est long à faire les tests ou on peut faire certains tests comme plus rapidement? Et justement, ben, en faisant les tests plus rapidement, est-ce qu'on peut voir directement un effet dans notre pratique ou dans notre traitement? Que genre un genre de test et retest. Donc, assez parlé, j'ai mis l'enregistrement sur la vidéo pour écouter le replay que je vais vous envoyer, le lien à tout le monde. Alors, sans plus tarder, so Dr. Wolf, it's very nice to have you with us today again. So, your subject today, you're going to talk about neurological exams. So, tell us more about it.
Yeah, I intentionally picked the word neurological skills in the acupuncture clinic because it's not just about exams. I really feel like the more that I have been able to study neurological disorders and understand the neuroanatomy and the neurophysiology involved in those disorders, the better I can be as an acupuncturist. And so, it's not just about having the skills to examine somebody or perform neurological exams. It's really also the ability to just have the background information that allows you to understand at a deeper level what somebody's going through, because for me, that translates into making some changes and adjustments with my herbal therapies and my acupuncture protocols. So we're going to just talk about some common phrases that I hear in my clinic when patients come in, and what that elicits in my mind as far as further questioning. So let me first just provide a brief introduction for people who may not be familiar with me. I am an assistant professor of physical medicine at the Carrick Institute, which teaches a lot of clinical neuroscience courses for clinicians. I own a clinic in Minnesota. It's called Healing Response Acupuncture and Functional Neurology. And in that clinic, we specialize in neurological disorders. So I treat a lot of people with concussions, traumatic brain injuries, stroke, migraines, peripheral nervous system disorders, and all dizziness, vertigo. I treat a lot of vestibular issues. And so for the last 20 years, I've been in private practice. And then I also really love to teach. And so I've been teaching for over 10 years as well. And I last year published a book, The Concussion Breakthrough, Discover the Missing Pieces to Recovery. It turned into a 600-page book that's really a troubleshooting guide for patients, practitioners, caregivers, people that just want to learn more about concussions and perhaps why somebody has persistent symptoms. So that book is available on Amazon. And then because I recognized that, a lot of people with brain injuries might be a little intimidated to pick up a 600-page book, I started a podcast where we could talk about a lot of the topics that are in the book, and allow me to interview a lot of colleagues and people in the field that are doing really incredible work. I didn't ever expect to have my own podcast, but I really found that I loved it. It's been really fun. It's a lot of hard work. It takes up a lot of time, but I really do enjoy it. So, but I've had a lot of fun in last year with the podcast. And then I've also been involved in clinical research as well. There's a study that we published in 2024. It was called Acupuncture Treatment for Chronic Post-Traumatic Headache in Individuals with Mild Traumatic Brain Injury. And that was published in the Journal of Neurotrauma, which is a pretty major journal when it comes to traumatic brain injuries. So it was a great honor to have that paper accepted in that journal. And then we also took part in a clinical trial, acupuncture treatment for individuals with myasthenia gravis. And so the patients that enrolled in that trial would come to our clinic to receive the treatment. And so we were involved in the write-up and the publication of that as well. So those are just some of the things that I've been up to for the last year and a half since I was last in Quebec and taught in the fall, I think, of 2024. So that's me. And
Only that? It's
only
been a
that.
quite a busy year.
I know, I know. I kind of had a year of just saying yes to everything, and it's been busy, but
Yeah,
fruitful.
I'm on the Amazon website right now, and yes, the book is available, and in Canadian dollar, it's $48. So it's a good price for this kind of book.
Yeah, and people don't have to read it cover to cover. There, for patients, there's a questionnaire in chapter one that allows them to fill out the questionnaire, and then based on how they answer the different sections of the questionnaire, they can then be kind of guided to specific chapters that are most relevant for them. So
Mm,
somebody called it a choose your own adventure book for people with brain injuries. So I always tell
I
people
like it.
you don't have to read it cover to cover.
So if I understand well, let's say you have a patient that has a certain condition, you can go, like you say, you're doing troubleshooting. You're going, he has this kind of trouble. I'm gonna go to this page, and then there's like protocol questions about it.
Yeah, so a good example, like some patients really struggle with daily post-traumatic headaches, and so there's an entire chapter on post-traumatic headaches. And then some people don't have any issues with headaches, but maybe they have a lot of balance issues and dizziness and vestibular
Mm.
symptoms. And so those people can go read the chapter on balance and vestibular disorders. There's a chapter on sleep, there's a chapter on dysautonomia, which we'll be talking about today. And there's a section on brain inflammation. So yeah, each chapter is very kind of symptom specific to help people so they don't feel like they have to read the whole book.
Fantastic. Thank you.
Yeah. Which kind of brings me to this slide here, which is these are kind of the topics that I did cover in my book. But what I was really trying to do with the book and also with my teaching is to help people see the connections between all of these things. So, for example, if somebody suffers from headaches or migraines or post-traumatic headaches from a concussion, well, we have to start asking the question of, what is preventing that person from healing? And maybe they do have some level of dysautonomia that is driving their headaches. Maybe their difficulty with sleep, maybe they have severe insomnia, and so that's preventing them from healing. Maybe they also had a traumatic neck injury, which is so common when someone has a concussion, and they have more of these cervicogenic type headaches. And so being able to see how these different aspects all kind of feed into each other really helps to start to have a better clinical process for helping people with complicated conditions. So, one of the things that I really started to pay attention to is when patients come in, I find that they often make what I might call, what I say is like an ambiguous statement that could be interpreted in a number of different ways. And I think that there have been times when I have shadowed other clinicians or I have been in a student clinic observing or supervising. And what I would find is that a patient would come in and they would make a statement, and the clinician in charge of the treatment at that moment would basically kind of come up with their own interpretation of the statement and then just move right forwards without asking clarifying questions. And so, what I wanted to really dive into in the context of neurology specifically is asking ourselves, do you know with 100% certainty what your patients mean when they say things like, and fill in the blank? And so we're going to fill in these blanks a little bit. So this is one of the things that I hear all the time when people come in to see me and they've had a concussion. They'll say, well, they said my brain was fine, or my doctor said my brain was fine. What people actually mean when they make that statement is typically that their doctor did an MRI of their brain and they didn't see any gross abnormalities on that image. So if people are being told, well, my brain is fine because I had an MRI, and yet they're still very symptomatic, and they don't have kind of a clear diagnosis or understanding of what is going on, it's typically because there are things that didn't get examined. And so when I hear this, I start asking more questions. I start asking, did anybody do a comprehensive autonomic nervous system exam on you? Did somebody do a comprehensive vestibular and balance testing? Did they look at not just your visual acuity, but how your two eyes are working together? Did they look at like how your hearing may have been affected? Did they do a sensory motor test? I start asking about all these different exams, and many times the answer is no. No, they didn't do any of these tests. And what is happening with the medical system is people are becoming very reliant upon brain imaging and lab work. And they're not kind of defaulting back to these very, very important hands-on exams. And because of that, people are kind of being told, well, we don't know what's wrong with you, and so we can't help you. So this is what I love to teach because when we can do exams, we start to figure out all kinds of things that aren't working right within a person's nervous system. And then we can start to have some objective markers that help us to really assess whether or not our treatments are helping them. So I'm going to give a few more examples here, and then we're going to get into kind of some aspects of the autonomic nervous system. Many people will also say they come in and they have some kind of dizziness or vertigo or balance issues, and they'll say, oh, well, they checked me for vertigo and they said I didn't have it. So usually what people mean when I hear that is that they went to a physical therapist who maybe tested for benign paroxysmal positional vertigo and they didn't see any evidence of it. Well, BPPV is really just one cause of vertigo or dizziness. There are many others. And even in the testing of BPPV, there was a study that came out that said that if you're not using infrared goggles in your positional testing for BPPV, that your diagnosis is probably going to be wrong about 50% of the time. And so if some PTs are just kind of having someone tilt their head back in a couple different directions and see if they get vertigo, that's not a good enough test to really rule that in or out. Sometimes people can have BPPV, but these crystals in the ear, they can actually adhere to the wall of the canal. And so unless you use some vibration on the mastoid bone to kind of shake those crystals loose, you could also miss the BPPV because those crystals have kind of temporarily gotten stuck onto the wall of the canal. So sometimes there's little tricks that people need to employ in order to get a good, clear test. So the other thing I see is a lot of people may not have vertigo, but when I ask them to describe what they're feeling, they don't have the terms because they the average public doesn't have a background in medicine. And so the average public may not have a good vocabulary with which to explain their symptoms. So it's the more that we have that vocabulary, the more we can ask better questions. And so when people say, well, I don't, they'll say, oh, I have vertigo. And I'll ask them, well, is the world spinning? And they'll say no. And I say, well, do you feel like you're spinning? And they say no. And so they don't actually have true vertigo, but they don't really have the vocabulary to describe what it is. So then I start giving them new vocabulary terms. And I'll say, well, do you feel like you're on a boat? Do you have a sense like you're kind of swaying forwards and backwards and side to side? And in many cases, people will say, yeah, it's more like that. And then sometimes I can have them while they're sitting in the chair, I have them shift forward in their chair so their back is not resting against it. And I'll have them close their eyes. And as soon as they close their eyes, I see that they maybe are kind of rocking side to side, or maybe they're rocking forwards and backwards, or they have this kind of like maybe just their head is kind of moving around. And so we can really quickly figure out this person has something going on with their vestibular system. But even though it's not a true vertigo, it's still a vestibular disorder. And so there are, having the background knowledge on how these different sensory systems work and the anatomy of those systems and how they integrate together has become the key reason for why I'm able to help a lot of people with complex neurological disorders is because I can test each of these systems by themselves, and then I can also test them together. And I'll get into kind of more of what I mean by that in a minute here. And then what I also find is that a lot of people that have vertigo or dizziness, they don't actually have a good working diagnosis into if they don't have a BPPV diagnosis, sometimes they don't have any diagnosis and they don't even have an understanding of is this coming from the actual peripheral vestibular system or is this a centrally maintained vertigo? And in the case of vestibular migraines, that becomes important. I had a patient who was having vestibular migraines, and when she came in to see me, but she didn't quite have a clear diagnosis, and she had been struggling for 4 years. And so we were able to really give her life back by doing a combination of acupuncture to help with the back of the neck and some points on the head in conjunction with some what I would call like head-eye vestibular therapies. But when I put the goggles on this patient and I looked at her eyes, she had a nystagmus that was like a right beating nystagmus. And then all of a sudden it would be an upbeating nystagmus, and then it would change, become a left beating nystagmus. And so her nystagmus kept changing directions. And you can see that type of instability in a case of a vestibular migraine, but you can also see that type of instability in a case of spinocerebellar ataxia, which is a neurodegenerative condition. And so, because I did see that in this woman who was in her 60s and had a history of cancer, I did actually refer her back to her primary care doctor to do a brain MRI just to rule out a more serious spinocerebellar ataxia because she did have some gait issues as well. Her brain scan was normal. We were able to move forward with treating her with this vestibular migraine, and now she's doing great. But these are just some of the things that I see in my clinic and that I have to work through with people. The other thing I see, this is more so with my concussion patients, is they'll come to me and they'll say, I have a lot of blurry vision. I have a hard time looking at phones. I have a hard time doing work on the computer. I went to the doctor and they said my eyes were fine. So what people usually mean when they say that is they went to the eye doctor, they checked their visual acuity and they didn't see anything. Their prescription hadn't changed. And so then they're kind of sent away. So a lot of times, maybe the doctor they saw didn't wasn't concussion informed and didn't do a thorough eye exam to look at how the two eyes are working together. I interviewed an optometrist for my podcast, and he said, eye doctors are supposed to check for eye movement disorders, but a lot of times they like go through those tests so quickly that they actually miss something that's there because they see it as kind of this routine thing that they just go through so fast that they kind of gloss over it and they just either miss it or maybe it's subtle and they don't think it's that important and so they skip it. So the other thing I see too is that people with concussions often lose their peripheral vision, and that can cause a lot of problems. And so some doctors don't perform more comprehensive peripheral visual field testing. One of the doctors that I work closely with has a really cool machine that actually tests for peripheral vision with red light, green light, and blue light. And so he'll have like a blue kind of dot that comes into someone's vision. They have to say when they see it. And they kind of map these like blue dots coming in, and then they do the same thing with the green and then the red. And then you get these like graphs of like, here's the person's peripheral vision for red, here is what it looks like with green, and here's what it looks like with blue. And so they've found that people that have mold exposure often have a reduced peripheral vision when it comes to the color green. That's become this like interesting kind of defining feature of people with mold toxicity or mold exposure. So, side tangent, but visual peripheral vision testing is important. Visual suppression is important too, and that's something that often maybe gets missed or ignored. People with brain injuries can sometimes ignore vision coming from one eye or the other. And that can be transient. It doesn't happen all the time. It can kind of come and go, but it can cause problems. People often have visual motion sensitivity. So you'll hear people say, I just have a really hard time going to grocery stores where there's lots of bright lights and lots of items on the shelves and people are moving back, all different directions. I hear that very commonly, especially with those big box stores like Costco and Sam's Club and Walmart. And so in that case, we have to understand that people's brains are getting their motion mixed up with motion that's happening outside in the environment. And it's making them feel really off balance. And so the more we can just kind of understand how our system is wired, the more we can kind of troubleshoot when people come in and they say, I was told I was fine, and I know I'm not fine because I have all these symptoms. What do we do about it? Like, how do we navigate that? And then the biggest thing I see too is that I mentioned this earlier. Sometimes if you test someone's balance by itself, it's great. But then they say, my balance by the end of the day is terrible. And so usually when you see where somebody in your office, they might do just fine with an individual test, like follow my finger back and forth. Oh, the pursuits look good. But then all of a sudden, what happens if you have somebody, walk down the hall and do 10 squats and turn their head, and then you have them follow your finger? Well, now all of a sudden they might not be able to. Or if somebody's balance is good, what happens if you play distracting music? Well, all of a sudden their balance might get worse. And so this concept of sensory integration, I think it's the future of neurology because what happens is people their brain has a hard time having good balance if their other senses are kind of overwhelming them. If they're visually overwhelmed, if they're auditorily overwhelmed, if they're cognitively overwhelmed, then their balance falls apart. So while their balance might be fine when you test it by itself, as soon as you bring in these other components, well, now it's not fine anymore. And that's the real world. That's the scenarios that we live in. And so many people say, I'm being tested, but, like I had someone just the other day, she said, I had a concussion. When I went to the vestibular physical therapist, they ran me through their balance tests and they said, well, your balance tests are fine, so we don't know what to do with you. And so really what was happening was that sensory integration piece, they didn't understand the importance of that. So they just said, well, your balance is fine, so you're discharged from our care. You don't need to see us anymore. And yet here she's saying, my balance is not okay. And so my therapy for her was doing all kinds of sensory integration techniques where I'm having her do eye exercises while she's bouncing in a tandem stance, or I have all these like colored silks, and so I'll throw up different colored silks, and she has to name the colors while she's balancing on one foot. Or I have her, doing some kind of balance exercise while I'm giving her math questions. And so all of her therapy is having her do balance exercises while simultaneously having to do cognitive tasks and maybe simultaneously having to move her eyes in certain directions. And so usually once you do that kind of sensory integration work, people then they get better much quicker. And so that's something that, again, just requires a really high level of basic understanding of how the systems work individually and then how they're supposed to work together. The other thing I often hear people say is, my hearing was fine. Like during COVID, so many of my patients would say they had fullness in their ears, they had dizziness, they had itchy ears, they had tinnitus, and they go to their doctor and their ENT would say, your ears look fine. They look in the ear for 2 seconds and say, your ears are fine. Well, they're not fine. They're having all these symptoms, right? And so this is where I think that as Chinese medicine practitioners, as acupuncturists, as herbalists, we have a lot to offer people when the kind of Western medicine system just says, well, I did my 2 second test and I didn't see anything. And so then people are left wondering, what do I do now? I was told I was fine and I'm not fine. The other thing is that there's a huge connection between the ears and the jaw and the neck and even the vagus nerve. And so a lot of people, if they have neck issues, that can affect things like tinnitus. If they have jaw issues, that can affect things like tinnitus. It can also affect balance. So those are some of the things I think about when people complain about tinnitus or hearing issues. That same patient that was having the balance issues I mentioned was having tinnitus, and I gave her Wendantang, the herbal formula, warm the gallbladder decoction. And she all of a sudden she's like, my hearing is better. And she had had hearing loss for many years. So Wendantang, it helps the endolymph in the inner ear. So we have this special fluid in the inner ear, and that fluid can be congested. And so that herbal formula actually helps like recycling of that endolymph. And so in that regard, in a sense, it can help to address dampness and stagnation within the inner ear, causing things like fullness in the ear, tinnitus, vertigo, motion sickness, nausea, those types of symptoms. So anyway, we talked a lot about balance. So I'm going to kind of skip over this one because I want to talk about one that is newer, something that I'm hearing more often. And that is this. People are now coming into my clinic and they're saying things like, my vagus nerve isn't working. And so when people say things like this, because it's all over Instagram and TikTok, and people are talking about the vagus nerve and vagal nerve stimulation, and everybody's asking whether they need that or not because it sounds like a cure-all. So when people say my vagus nerve isn't working or things similar, what they often actually mean is I'm stressed out, I feel overwhelmed, I'm tired all the time, my sleep sucks, I have digestive issues, I'm anxious, and I'm symptomatically meeting all of this criteria that people are talking about when they talk about the vagus nerve underperforming. And so this is what I wanted to talk a little bit about today, along with this thing that I'm hearing, which is that people are now coming into my clinic and they say, I think I might have POTS, postural orthostatic tachycardia syndrome. And so this is something that when people were getting COVID, COVID in some cases was causing POTS, and in some rare cases, people who maybe were already had some kind of mild form of dysautonomia, if they got either the COVID vaccine or they got COVID itself, it could throw them into a more severe dysautonomia and a POTS-like state. So that's where in the last 5 years, more and more people have heard of this term, and it affects women, 3 or 4 times more than it does men. So in many cases, I have, women coming in saying, I think I might have POTS. And so oftentimes what they're really trying to communicate is a set of symptoms. and they're saying, I get dizzy and I get lightheaded a lot. I can feel my heart racing. Or maybe they have increased heartbeat awareness where their heart feels like it's racing, but really the rate itself might be normal, but the heart is like pounding. So they have this like increased pounding sensation. Sometimes they might say I'm nauseous, like on and off for no clear reason. A lot of times people that have dysautonomia, they feel uncomfortable in their own body because these things, this unconscious system that's supposed to regulate everything isn't doing it very well. So these people are often anxious all the time. They maybe have a hard time exercising. They don't feel good if they exercised, or they feel a lot worse after. And in many cases, their sleep is off too, because our autonomic nervous system also regulates circadian rhythms. And so when I have somebody come in that says, I think I have POTS, it's real easy to test that. And I have a tilt table in my clinic, but you don't need a tilt table. You can simply have somebody lay down and you take their heart rate and their blood pressure and you pay attention to their respiratory rate. And then you have them stand up and see what happens to their heart rate technically for 10 minutes. It's a boring test because you need them to stand up and then not talk for 10 minutes. But usually within the first 3 minutes, I have a pretty good idea as to whether or not they've got POTS or not. So so these are the things that maybe it is because I specialize in neurology that I see this a lot. And so maybe my experience is not other people's experience, but I definitely have noticed in the last 5 years more and more people coming in and asking these types of questions and having these types of concerns. So I wanted to talk about this concept of what is the difference between autonomic nervous system dysregulation versus dysautonomia? Because they really are two different things. And so the point I want to make is that you have a lot of people walking around these days that have autonomic nervous system dysregulation. These are people who are tired but wired, right? Maybe they have a lot of anxiety, so they never really feel like they can relax, but they're also fatigued a lot, chronically stressed out, chronically overwhelmed. Stressful triggers might lead to over-exaggerated responses. They often feel kind of easily triggered and easily stressed out. Many of these people are going to have poor sleep, usually diagnoses that include anxiety and depression, and maybe they have poor memory, or they say their memory isn't working very well, and then possibly nausea. So this could all be a sign that the autonomic nervous system is dysregulated due to stress or trauma, but it doesn't automatically mean they have dysautonomia. And so I wanted to talk a little bit more about that. So again, these people that come in that have diagnoses of anxiety, depression, maybe post-traumatic stress or post-traumatic stress disorder, insomnia, these chronic people who are chronically stressed, we have to recognize that this isn't really dysautonomia until it's proven to be such. And because a lot of people do come into my clinic and they've heard this word dysautonomia and they feel like they meet a lot of the symptom criteria. And so some people are kind of labeling themselves as having this without really understanding what dysautonomia is as a medical condition. So we could define dysautonomia as a true medical condition where the autonomic nervous system is physiologically dysregulated, and this is usually due to trauma, an infection, an illness, some type of autoimmune disorder, or a coexisting disease like Parkinson's disease or ALS. Or there are some rare genetic conditions that will actually lead to autonomic failure. So dysautonomia, I think it's important to understand, like it is a medical condition. It certainly still has a continuum in terms of severity, but we want to make sure we don't have people kind of just labeling themselves as having a medical condition if they truly don't. But we also want to be able to give them some education around what is it and what isn't it, and then how do we test it. And so we can just simply say, oh, I think I skipped a slide here. There. Uh, so dysautonomia can be measured. It can be tested. And so some of the things that can be used to test it are using pupillometry, so looking at the pupillary light reflex. There's a simple 5-minute hand grip test that we can do to look for dysautonomia, because if you're doing an isometric contraction for 5 minutes, your diastolic blood pressure should actually increase by 20 points during that 5 minutes. If it doesn't, it's a sign that the sympathetic nervous system is not responding appropriately to a physical demand. And so that could be a sign for why somebody might have exercise intolerance. And then we can do the tilt table testing or the supine to stand test to look for different aspects of orthostatic intolerance. And not all orthostatic intolerance is POTS. For some people, it's more of a orthostatic low blood sugar, right? A hypotension. For other people, it might just be more of an exercise intolerance. So that's where we would do like a Buffalo concussion treadmill test or see, when we ask somebody to exercise, what happens with their heart rate, their blood pressure, their respiratory rate, and then what types of symptoms come on. Then there are ways that we can actually perform deep breathing and Valsalva maneuver tests. Even like in our clinics at the bedside, we can do some of these tests if we just have a bit more of a higher tech heart rate monitor. And then that tells us kind of what their level of parasympathetic activity is. So what's really nice is that some people might come into my clinic and say, I've heard about these vagal nerve stimulators. I'm wondering if I need one. Well, I can just run them through some quick, autonomic tests and do a deep breathing test and do a Valsalva test at the bedside. And if their kind of heart rate numbers respond appropriately to those tests, well, then maybe I can say, your parasympathetic nervous system is responding appropriately. So, maybe you don't need to go spend hundreds and hundreds of dollars on some device. Maybe you just need some better stress management tools in your life, because your actual nervous system is working appropriately. And then at these higher level, like clinics like the Mayo Clinic, they might actually perform what's called a quantitative pseudomotor axon reflex test. And this is a basically where they put electrodes on your skin, they have a temperature controlled room, and they're changing the temperature and they're assessing your degree of sweating. Because sweating is, in part an autonomic response. There can be an emotional component to sweating. When people are anxious, they'll start sweating, but there's also an autonomic response that you should be able to see. And then in other cases, a muscle biopsy to test for small fiber neuropathy might be in order as well. And those last two really require more of a specific autonomic lab that's usually in a hospital setting. But these are just examples of like real actual tests to assess for sympathetic function and parasympathetic function and to ask the question, are they responding appropriately or are there signs of a true medical dysautonomia? And so we can say quite simply then that dysautonomia as a medical condition includes autonomic dysregulation, but not all autonomic dysregulation is automatically dysautonomia. And one of the simple tools that I'm going to talk about in my course when we talk about neurological exams and neurological disorders in May is the use of the Compass 31. And this is a questionnaire that was developed by the Mayo Clinic back in the early 1990s for people or patients that had a suspected autonomic dysfunction. And so it started out as 169 questions and across multiple domains of autonomic function, which we'll talk about on the next slide. But what they found was asking the patient to fill out a questionnaire with 169 questions was just too time consuming for them. And so after years and years of collecting data, they basically did a huge statistical analysis to figure out of these 169 questions, for the people that had a true medical dysautonomia, which questions were most indicative, like which were the ones that people answered yes to most often, and they were able to shorten it to 31 questions. And so that's where we get the Compass 31. And there are 6 different domains that they ask about. So they ask about orthostatic intolerance. They ask questions about, how do you feel when you stand up? They ask questions about the vasomotor system. So things like, do you have flushing? Do you have hives? If you have too much vasodilation, people might faint, right? And then they ask about secretomotor functions. So vasomotor and secretomotor are both involved in kind of sweating and temperature regulation, but they are 2 distinct systems. And so they ask about, a lack of sweating or heat intolerance, and or whether, someone has spontaneous sweating. They ask about gastrointestinal symptoms because many people with dysautonomia have what we call functional gastrointestinal dysfunction. And then they have questions on bladder function and pupillomotor function. So are the pupils responding appropriately, or does somebody maybe have severe light sensitivity? And then each domain is weighted. So this is the way to score this is not like simple mathematical calculation. You actually need an Excel spreadsheet with the built-in equations in it to get the right score. But for example, a question in the orthostatic category would say, in the past year, have you ever felt faint, dizzy, goofy, or had difficulty thinking soon after standing up from a sitting or lying position? So if somebody says no, well, then they can skip ahead to question number 5. If they say yes, then they go to question 2. So then they want to know, when you're standing up, how frequently do you get these feelings or symptoms? How would you rate the severity of them? And in the past year, are they getting better, staying the same, or getting worse? And so, of course, each of these kind of has its own point category. So, for example, in question number 4, if somebody says, "Well, it's gotten somewhat worse," well, they get a 1.5 score on that. So, like I said, it's not like a perfectly straightforward way of scoring this test. But the point I'm trying to make is that you can have a patient fill out the Compass 31 and immediately get the feedback that you need to say, how concerned do I need to be about their autonomic nervous system? And so if somebody has a score of 30 points or more, it's usually a strong indicator that they've got some kind of primary dysautonomia. Somebody who maybe gets a concussion and develops a certain amount of kind of autonomic dysfunction, they might score between 10 and 29. And in that case, you could be considered a secondary dysautonomia due to some kind of sensory errors in the system from that concussion. And if somebody has a score below 10, that means you probably don't need to worry too much about spending the time to do a bunch of autonomic assessments. So I interviewed Dr. Antonucci, who's one of my mentors. He's one of my teachers. So if you want to listen to the podcast, episode 31, it's a free conversation where we talk about a lot of this stuff. The other reason why I'm talking about it is because what I discovered in my work, I've been kind of teaching about autonomic issues since about 2018, when I taught a course called Improving the Function of the Gut-Brain Axis. So what I started to realize is that if we looked at the different questions on the Compass 31, we could map all of those questions back to the 5 functions of qi. And so when we look at orthostatic intolerance, which are questions 1 through 4, that really brings it back to the functions of transporting and raising the qi. And questions 5 through 7 are all about like skin color changes, which we could say have to do with the warming function of qi. Questions 8 through 11 are about dryness and the inability to sweat. And so that comes down to that protecting and defending. We know that Wei Qi helps to control the opening and the closing of pores. And so when we have Wei Qi stagnation, maybe the pores don't open appropriately and somebody has an inability to sweat, they develop heat intolerance. If somebody has internal heat, then they might have dryness on the surface. So we start to look at how these kind of questions and these dysfunctions of the autonomic nervous system relate back to concepts that we learned in our first year in acupuncture school. Questions 12 through 23 are all about digestion, and questions 27 through 31 are about kind of dry eyes, or I should say the light sensitivity. And so these are all about transforming the function, transforming chi, right? And then questions 24 through 26 are on urinary incontinence, which really is about the holding and containing functions of chi. And so what I really like to do is it can be very intimidating when you have somebody come in and they have a dysautonomia diagnosis and they're highly symptomatic, and you're asking yourself, where on earth do I start with this person? We can use a questionnaire that they fill out before they even set foot in the office. And by how they answer the questions on that Compass 31, we can immediately understand which aspects of the nervous system aren't functioning. And then we can bring that back to our five functions of chi. And before this person even sets foot in your office, you already have a game plan for understanding how to work with them by simply doing what you already know how to do so well, which is regulate chi and to improve these five functions of chi. So by being able to take a complicated neurological diagnosis and then have a simple questionnaire without even doing a single neurological exam, you can actually have a game plan. And so, a lot of what I'm trying to do is take these neurological disorders and help us as acupuncturists be able to help these people and not get lost or confused in the biomedicine or in the diagnoses that might seem intimidating. And so that's really kind of what we're going to do in this class in May. It's not just about having to learn exams. It's about taking complex issues and just making them simpler. So, for example, the Compass 31 question 8 through 11. So, in the past 5 years, what changes, if any, have occurred in your general body sweating? Do your eyes feel excessively dry? Does your mouth feel excessively dry? Or for the symptoms of dry eyes or dry mouth that you've had, have these symptoms gotten better, gotten somewhat better, stayed the same, gotten somewhat worse, or gotten worse? And so those are the questions. And we can bring all of that back to this idea that if we're talking about protecting and defending, we understand that we have this lung qi that circulates wei qi. Wei qi protects against invading pathogens and environmental factors, and it controls the opening and the closing of the pores. And so we can understand that if somebody has an inability to sweat, or maybe they have spontaneous sweating, a lot of times they'll also have things like lowered immune function. And so now we might have somebody with dysautonomia and an autoimmune disease. And now we can kind of bring it back to these simple aspects of how did they answer those questions? If they've had a QSART test, maybe it showed altered pseudomotor output. If they had lab work, maybe we're seeing some labs like an elevated ANA marker, which is kind of your first pass screening of autoimmune disorders. But when we can bring it back to let's help improve this particular function of protecting and defending, well, then we know kind of that we have a game plan on how to help this person. And so this is kind of what some of the things that we're going to talk about over the weekend. And I have kind of like a whole lesson where I get into different types of POTS and what causes POTS. And one of the confusing things is that people that have hypovolemia, so we could call that like a fluid deficiency. A lot of times those people, because they have low fluid volume, they have postural tachycardia syndrome as a compensation for the hypovolemia. Well, they will often say that they feel hot, but their skin is not warm to the touch. And that could be confusing to the clinician until you start to understand these concepts of the autonomic nervous system. And then we can talk about different herbal formulas like Sheng Mai San that can help the patient that has a hypovolemic POTS. And that would be a very different strategy than somebody that has what we would call hyperadrenergic POTS, where the elevated heart rate when standing is actually because of an excessive release of norepinephrine. And so that's a very different mechanism requiring a very different treatment strategy. So basically, my whole goal in teaching is to, again, take these complicated concepts, bring it back down, just basic biology and what's happening in the system, and then correlate that with what we already know as acupuncturists to make these things a little bit simpler to understand. And then figure out, well, then how do we treat them? So when people come to you and they are saying things like, I have all these symptoms, but they told me I was fine. We want to ask, who gave them their original diagnosis? How many doctors have they already seen? I can't tell you how many people that have Meniere's come in and they say to me, well, I went to one doctor and they told me I had Meniere's. I went to a different doctor and they told me I didn't have Meniere's. And so I hear that all the time. So a lot of these people are coming to me and there's a confusion. They say, well, one doctor said I had vestibular migraines, the other doctor said I didn't have vestibular migraines. And so we need to be able to just meet these people where they're at, treat the person, not the biomedical label, and be able to have this understanding of how to assess them and how to interpret those tests. So I'm always asking myself, who gave them a diagnosis? Or, was it ChatGPT or was it a doctor? What tests were performed? What tests have not been performed? Are they getting the right care? Where do I fit into the equation? If they're already seeing five other doctors and one doctor's trying to do stuff with their eyes and another vestibular PT is trying to do something with their balance, and then this other doctor's putting them on 50 different supplements, it's like, where do I fit into that equation? And what am I offering that's different from what they've already done? Because most people that come to see me, they've already seen 10 other doctors. So can I do something different? Like, do I even have a different approach that might actually have a different outcome? And then what do they want from me? The most important question I think I can ask my patient is, if there was one thing that I could do for you, what would that be? What is it? Because I might say, oh, well, you have postural orthostatic tachycardia, so I want to help lower your heart rate. But maybe the one thing they want me to do for them is like fix their nausea, right? So we want to know, like, what is it that they want to see change? Because it might be different from what you think. So that's kind of the gist of today. Today was kind of just like this big picture thinking of looking at these patients a little bit differently, maybe through a different lens, and then just getting a sense of the questions that we'll be exploring throughout the weekend, and obviously the answers that we're going to be able to come up with at the end of that too. So when I first see patients, on that first day that I see them, I spend a lot of time up front examining them. And I got this from Dr. Antonucci, so I'll give him credit where credit's due. He says to his patients, on day one, I want you to see me as Detective Antonucci. Like, I'm not your doctor, I'm your detective, and I'm going to try to get down to the bottom of what it is that you have going on. And then once we do that, then I get to be Dr. Antonucci. But first, I'm Detective Antonucci. And to be able to approach our patients with that level of curiosity and willingness to listen and look and learn and observe, that's really, I think, what sets us apart. And that's a gift that we can give people that is life-changing at times. So I know I've run out of time. Real quick, this is my book and kind of how I broke down the chapters in the book. As Francis said, it is available on Amazon in Quebec. And then this is my podcast here. It's called Life After Impact, the Concussion Recovery Podcast. You can find it on YouTube, Amazon Music, Spotify, Apple, all the places. And then on May 1st, I'm going to be doing a deep dive into migraines, which are not just headaches. Migraines are an altered brain state. Migraines are a sensory processing disorder. And so when you're dealing with people with chronic migraines, you have to look at it very differently than just a headache. And then May 2nd and 3rd, we'll be getting into all things neurology. So Thank you for listening and attending. It's been great.
Wow, fantastic. Thank you, Ayla. It was very inspiring. I took a lot of notes
Good.
during the live. So many valuable information for me and as well for my colleagues. So I'm gonna share the live. I'm gonna share some of the hints that you gave. But sometimes you just say like a thing, and that reorients the, like I would say, the approach and everything. One thing I noticed, it was that the first day Dr. Antonucci said, "I'm not your doctor, I'm the detective." And the one thing that you ask your patient, the one thing that I could do for you that will make a very big difference, what would that be? And that may be different from what you're thinking of. So yeah, cool.
Yeah, I don't teach practice management, but I do feel like I do teach practice management more in the sense of being able to effectively communicate with people that have really complex cases. And the more that you can communicate things in a way that develops trust and value, then the more the patients are willing to work with you and follow your treatment plan. And these days people's attention spans are very short and they want very fast results. And so kind of we have to be exceptional in order to even capture people's attention and their willingness to work with us these days. And so I feel like my classes, what I'm hoping to do is just, allow our profession to stand out as people that can offer a natural solution to neurological disorders, because in the field of neurology, doctors have brain surgery and they have drugs. Those are the only two tools in their tool bag. And so we've got to offer better tools for people that don't need brain surgery or don't respond well to the drugs.
Yeah, and you have a great ability to, let's say, take something more complex and bring it to very the basic, and just like the slide number 21 with the compass test, 31, and the 5 functions of chi. So when somebody's coming with a lot of diagnosis and symptoms and everything, and then you're breaking it down to the basic, it's like, okay, I'm gonna take it this way instead of, oh my god, he has a list of symptoms, where do I start and everything. So that,
Yeah,
honestly, I know that could be very helpful for a lot of people. So yeah, because sometimes it can be impressive or intimidating. So
yeah,
yeah. Wow.
yeah.
Thanks a lot again for your time. I really enjoy
Mm,
it. I'm pretty sure my colleagues did and will enjoy it with the replay. So we'll keep in
mm.
touch for May for everything. And I hope you're going to have a warmer weather in your hometown.
I'm ready for spring.
Yeah, me too. All right. Thanks a
Okay.
lot. Merci beaucoup tout le monde d'avoir été là pour le
Thank you.
replay ou en direct. On se tient au courant. Je vous donne des nouvelles dans le groupe et par l'infolette. Merci. Bonne journée. Have a good day.